Hello, my name is Dr. Eric Hollander, and I'm director of the Spectrum Neuroscience and Treatment Institute and Foundation. And I'm very pleased to be speaking today with Dr. Natalie Rasgon, who's a professor of psychiatry and obstetrics and gynecology at Stanford University School of Medicine, where she's also director of the Center for Neuroscience and Women's Health. And Professor Rasgon has made important contributions to our understanding of different phases of female reproductive lifespan and the impact on mood disorders, obsessive compulsive disorder, as well as eating behavior, for example, and even weight and metabolism.
Absolutely.
So it's great to have you here.
Thank you.
And so I understand that you think that there are some differences between men and women. Tell me about that and how those differences, for example, impact sort of the course of illness of mood disorders or the presentation of mood disorders.
So it's fascinating to think that women actually are twice as vulnerable to develop mood disorders, specifically by unipolar depression, major depressive disorder. And the prevalence of the unipolar depression in women is 2 to 1 in comparison to men. The gender difference in that risk begins with the onset of puberty. So there is a pretty strong connection to the reproductive stage of life, as puberty kind of denotes the beginning of reproductive life in a woman, more so than we know it in men. That difference remains exactly the same until the menopause, and then post-menopause, women and men catch up in prevalence of mood disorders. The other interesting thing is that in a bipolar illness, when it's a manic depressive illness, bipolar 1 disorder, when it's a mania and major depression, there is no gender difference, but there is gender difference in all other subtypes. In fact, women are much more likely to have bipolar 2 and rapid cycling disease. So there are some differences. There's also difference in the age at onset, for example, of mood disorders. So for example, women would develop it later in life than men. So young women usually develop unipolar depression in their mid to late 20s, where a man may develop it in their early 20s. We actually published a couple of years ago a very interesting paper looking at the 6 differences in the age and onset of bipolar illness between boys and girls and how that impacts the course of bipolar illness. And we found that for the boys, peripubertal onset of bipolar illness, and we know that when it's in childhood, when it begins in the childhood, it's usually more difficult illness to treat. In boys, it is less affecting their functioning than when it starts early in girls. So again, there is a certain disparity in the way women are affected with mood disorders.
So it's a huge difference if it's at least double the risk then for mood disorders or broader bipolar spectrum disorders, and not in early childhood or late in life, but in particular during, after puberty, in sort of the postpartum type period and up until menopause. So what do you think accounts for those big differences?
So one of the main theories, the neurobiological explanation, is a result of the endocrine milieu. So the ovarian steroids, estrogen and progesterone, which of course are only present in women and have this cyclical production, affect the mood in a sensitive group of population of women. So for example, women who have some genetic and familial liability to have those illnesses are more sensitive to the change in the concentration of these hormones. And that denotes the premenstrual dysphoric disorder or just PMS, or quite often the premenstrual worsening of the underlying psychiatric illness. So it could be anxiety disorder, for example, which gets worse in the luteal phase preceding the next period rather than just throughout the whole month. Similarly, with obsessive compulsive disorder, for example, their obsessions may become more frequent and more difficult to control in the luteal phase, and then they become a little less disturbing in the follicular phase right after menstruation.
So it sounds like these are important gene by, I guess, environment, by gender type
yeah, exactly.
interactions, right? And and there's a cyclical nature of all of these sort of hormonal fluctuations that have some impact on the expression of the symptoms?
Absolutely,
Yeah.
and so because as you rightfully said, and I think it's a very important thing to understand, that people at the best years, most productive years of their lives are affected the most. So for a few decades of the reproductive life, women have all kind of additional risk and vulnerability. And the cyclical nature of the hormone production affects this population. I wouldn't say that it's every woman, but there is about 5 to 10% of women who are exquisitely sensitive to these changes. And now we have a much better way of diagnosing them and then applying differential way of treating them to adjust for that premenstrual worsening. So that would affect their psychopharmacology, it may affect other non-pharmacological interventions, etc.
You know, we had Mary Jo Cody, who is the wife of the former governor of New Jersey, on talking about, you know, a lot of the work that she's been doing for postpartum depression and postpartum psychosis, I guess. So maybe you could say a little bit more about the impact of these sort of hormonal changes around childbirth and the development of postpartum depression and postpartum psychosis.
Yes, that's a huge issue. Postpartum depression in a first-time pregnant woman is prevalent in about 20% of cases. So it's very high. So it's between 10 and 20, and we think that it's underreported because women tend to minimize their symptoms during pregnancy, and they tend to believe that they're supposed to be very happy being pregnant, and so we don't necessarily think that every woman who is depressed reports it right away. But said that, pregnancy is very interesting endocrine stage of woman's life. So during pregnancy, the changes in estrogen and progesterone go up exponentially in orders and orders of magnitude. And towards the end of pregnancy, women have the highest of their all lifetime exposure to these hormones. And then what denotes the beginning of the labor is actually this precipitous drop in both estradiol and progesterone, and that is the beginning of the labor activity. And because the drop is, I would just give you an analogy. It's like a huge waterfall. It's just ginormous, precipitous fall in concentration. It sponsors the mood changes in many women. So it's very common for almost 85% of women to have some changes in emotional regulation right after the labor.
Right.
So what is we know as called postpartum blues. But those usually are very temporary and they self-limited and they go away after 4 to 5 days. Postpartum depression is a very difficult illness to treat because it's insidious. It doesn't start right away, usually. And it's a very anxious, sleepless disease, which in many ways is rationalized by women because they need to get up in the middle of the night to feed the baby, they need to change the diaper, etc. So there's a lot of reasons for women not to think that they're actually depressed. And then we tend to get to understand their illness 2 to 3, sometimes 4 months after the labor, after delivery. In very difficult illness types, such as bipolar depression and sometimes psychotic depression. So postpartum psychosis, it's true psychiatric emergency, and it's associated with infanticide and suicide, and it's a very acute illness. It's traumatic presentation, and it absolutely in all cases requires admission to the hospital.
Now, some women have aggressive obsessions, right? So they can have horrific or intrusive images, for example, of causing harm to the baby. How do you differentiate the type of symptoms that you were talking about in postpartum psychosis, for example, from these aggressive obsessions that might get worse following delivery and OCD?
Right, exactly. So OCD usually tends to get worse, significantly worse in postpartum. I think, and not to be too technical about it, but in psychotic presentation, it's egocentric, right? So
right.
Women believe that their children are evil. One of the cases, very dramatic cases we have from 15 odd years ago was Andrea Yates, who believed that her babies were evil and she ended up killing all her children. In obsessive compulsive disorder, women are ego dystonic, so there is this worsening of this vicious cycle of them obsessing about harming and then feeling even worse that they're obsessing about it. So we actually see a lot of women, maybe not in a full scale of OCD, but even in a just postpartum depression, which is very obsessive in its presentation, right. Much more than depressive. We see that these women sometimes become suicidal just because they can't fathom the thought that they may harm their baby.
Right. So you mean the horrific, intrusive thoughts are so disturbing that they feel hopeless. Yeah. Now I know that estrogen has an impact on, for example, oxytocin receptors, and there's a lot of interest in the mother's oxytocin levels and what kind of impact that might have on mood-related states, or what impact that might have on the infant and issues around social synchrony, for example, and other developmental kind of issues. Maybe you could say something about that.
Yeah, I'd be happy to talk about it. I actually think that estrogen actually as a hormone is one of the most active biological agents we have in the central nervous system.
Mm-hmm.
However, and estrogen is acting as a kind of a natural, so to speak, endogenous antidepressant, antipsychotic, and pro-anxiety because it increases the amount of glutamate in the brain. It decreases GABA. Progesterone acts exactly in the opposite way. Progesterone is GABAergic and decreases NMDA. But at the same time, estrogen, if estrogen is given exogenously in postpartum cases to, say, augment the oxytocin release, it has its own medical repercussions, because in a lactating woman, so then when we think of oxytocin, we have to think of prolactin. So giving women large doses, which would be effective therapeutically, of estrogen in postpartum may lead to the cessation of lactation. And there are other medical reasons, you know, it may cause some coagulative problems with blood, etc. So use of estrogen was tried in postpartum depression. In fact, Kathy Wisner at Northwestern done a number of placebo-controlled studies of that. But estrogen it's not for every woman, so it's not necessarily the medication which can have widespread use in postpartum depression. It's much better used in aging and in transition into menopause.
Okay. Now you were also talking about sort of changes in OCD over the lifespan, I guess, in women as well. You have any other thoughts about that?
So I think that, again, whatever the interaction between the endocrine, between the hormones, the steroid hormones we're discussing today, like estrogen and progesterone, and the neuromédiators such as serotonin or norepinephrine, etc., dopamine, all of these permutations have a certain cyclicity and a certain capacity. Neurons have a certain capacity for that interaction, and with the aging reproductive system, when the reproductive system transitions at the end of reproductive period into quiescence, right, the ovarian quiescence, then the crosstalk, so to speak, between the peripheral production of these neuroactive steroids and the brain regulatory systems, it gets interrupted. So we do not have the same connection between the estrogen and progesterone, say, and the serotonin and dopamine. So in that regard, say, use of these agents in treatment of OCD or in treatment of depression or anxiety is not having the same effect as it would be during the reproductive life. So the doses may change, the type of administration will definitely change, so then we avoid the cyclical administration of any medication because we want to suppress the fluctuation of the hormones to avoid additional worsening of the symptoms during menopausal transition.
Okay, so I guess those times after puberty and around the time of pregnancy and with sort of changes during the menstrual cycle as well as in the, I guess, the menopausal periods, you'll have different kinds of interventions that might include modification of estrogen or progesterone levels, for example. We're thinking about how they affect other systems like serotonin or dopamine or the GABA-A system. That might influence other medications that you might use to treat some of these symptoms?
Absolutely, and just to kind of bring it more into the spectrum of what you mentioned in the beginning of our conversation, the weight changes. So women, much more than men, experience the weight fluctuations at the time of puberty and then at the time of menopause. And those are in many ways also relate to the reproductive hormones. However, in addition to that, they also relate to the hormone produced by pancreas, the insulin. And so the insulin, which we now understanding is a very powerful also neurotrophic agent in the brain, insulin interacts with dopamine. And so the disordered eating, say, as a part of the, say, reward regulatory deficit, may yield insulin resistance, and that which may become a pre-diabetic state and may be associated with a profound weight gain as a result of the disordered eating. So there's additional vicious cycle which surrounds those periods of woman's life much more prominently again at the time of this transition, at the time of pubertal transition into reproductive regulatory cycle, cyclicity, and then at the end when it goes from the cyclicity into asynchronous production and then into quiescence.
Now, I guess we used to think of these conditions as mental disorders, but you know, the brain is an organ in the body, and there are all these connections, I guess, between, you were mentioning the HPA axis or the pancreas, for example. So there are connections between the liver and the vagus nerve and the central nervous system. So we need to think about these issues as sort of systemic, whole body issues as opposed to just mental issues.
Absolutely, Eric. And I have to tell you, this is even more pertinent now because we have such a profound understanding, which we never had before, of how peripheral organs, especially like GI organs, have such a powerful presentation in the brain. So the liver is one of the great examples, and the liver-mediated insulin resistance, which is quite often associated with disordered eating. So if I go to McDonald's, for example, 3 times a day, and I binge on cookies or something else, all that impact will be mostly in the liver. The regulatory representation of that in the brain will be in the hippocampus. And that in itself will have a whole other lieu of problems which will arise from the hippocampal, you know, misfiring of the hippocampal neurons, and then whatever related neuromediators which are binding in the hippocampal area or hippocampal, perihippocampal area, they may have effects on memory, regulation, on learning, etc., etc.
Uh-huh.
So we now understand much more about how the peripheral metabolic dysregulation
Right.
affects the brain.
Right. So, for example, we used to think of mental conditions as like a binge eating disorder, and peripheral conditions as metabolic type disorders. But I guess you're saying that the impact of metabolism can affect reward seeking, and sort of central nervous system activity may impact peripheral metabolism as well.
Absolutely, and we have now at Stanford there's a study going on with children and adolescents who have mood disorders, and we're looking at their disordered eating as a manifestation of reward problem, deficit in reward processing.
Right.
So we look at the fMRI, the functional magnetic resonance imaging, and insulin resistance. So we approach them from the standpoint of understanding this vicious cycle between the disordered eating and how it's represented in the brain and how it's represented in the endocrine permutation in the periphery.
Right.
And we see that those children, they're very young, they all have metabolic dysregulation and profound, already identifiable changes in the brain circuitry.
We've been interested in rare disorders like Prader-Willi syndrome, which is a chromosomal disorder where children starting at a certain age develop compulsive eating, and also profound metabolic related issues, and that the hyperphagia or the central aspects of the behavior may be connected to the metabolism and vice versa.
Absolutely.
Yeah.
The question is, where's the chicken, where's the egg?
Right.
So I think that in your models, in those rare diseases, it's easier to define the causality rather than in more kind of a multifactorial neurological, neuropsychiatric illnesses.
Right.
Because we don't necessarily know what precedes. But looking at the children, I would suggest that it is possible that emotional dysregulation precedes the food intake, and then the vicious cycle begins.
Right.
So one kind of unfortunately negatively impacts the other.
It's kind of exciting that you're at sort of the cutting edge in two different fields. So there's been a lot of sort of work in women's health issues, and there's been a lot of scientific advances in neuroscience. It's nice to put those two areas together, right?
Yeah, it's very exciting, and I feel very privileged to work in that. And I have to say that my research, I always look at my research as a detective story character, so they kind of take me on the road instead of me dictating them. So whatever findings we have in our studies, we just follow the findings, and then the direction of research kind of evolves.
Right. Now, another thing that I think is unique is that you have a background not only in basic science research, but also in clinical and therapeutic sort of interventions in humans and adults and women, for example. So what do you think are some of the most important recent developments in terms of clinical treatment based on sort of some of the recent neuroscience advances that sort of inform new treatment developments?
So I think that both pharmacological and non-pharmacological interventions become now more oriented for specific gender. So for example, in psychopharmacology, we augment medications in treatment of mood disorders with the certain endocrine agents, for example, with estradiol, or in cases of postpartum, for example, depression. Right now we have the new agent which was just approved by FDA literally within a couple of months, which is a progesterone metabolite. It's an allopregnanolone, a very potent, very active agent which binds to the GABA-A receptor subunit and profoundly modulates anxiety and improves depression. So that is specific to women. So that is again something which pharmacology is now kind of finding a different more individualized and personalized medicine approach. The other is, as you mentioned, oxytocin, for example. So I think that oxytocin is at the forefront of research right now. I'm going to find significant therapeutic complication in women. In fact, again, especially in postpartum, could be in other times of women's life. TMS, the RTMS, we're now only now coming to potential understanding that women may be a very interesting group of patients to respond to TMS, and the studies are warranted to look at use of TMS, for example, in postpartum depression or in postpartum worsening of postpartum bipolar illness, etc. Something we have not really tried in the past.
Or even during pregnancy.
Or even during
you
pregnancy
may want to
instead of
avoid drugs that have
medications.
systemic effects.
Exactly.
Right? Yeah. Well, what you're saying is of great interest at the Spectrum Neuroscience and Treatment Institute. You know, we're very interested in applying TMS to a range of different conditions and using interventions like intranasal oxytocin to treat developmental disorders where there's an impact on things like social communication or social synchrony. And clearly, I mean, these things have a huge impact in sort of bonding related issues between the mother and the infant.
And the child, which
right?
is of incredible importance. And depressed mothers do not attach to kids well.
Right.
And we know that there are far-ranging, long-acting, forthcoming problems with the child development as a result of poor attachment.
Yeah, and when we think about early intervention strategies,
that would be intervention.
A key issue.
Yes,
yeah.
Absolutely.
During
no
the
question about it.
Postpartum period, right?
Yeah.
In terms
we just need studies. We really need more kind of targeted approach to studying those questions.
Okay. Well, so again, my name is Dr. Eric Hollander at the Spectrum Neuroscience and Treatment Institute and Foundation, and we've been talking with Professor Natalie Rasgon from Stanford University, where she is Director of Neuroscience and Women's Health and a Professor of Psychiatry and Obstetrics and Gynecology. And she's been talking about personalized treatments that use your understanding of these hormonal changes during different periods of the female lifespan, for example, or the monthly cycle, and how that can impact different brain systems that are involved in things like a mood or anxiety or obsessive thinking, for example, or reward seeking or metabolism. So you bring a wealth of knowledge and experience that can really design sort of individual sort of treatment plans for people. So
absolutely, and I'm very excited to be here. I find that your work is fascinating, and I think together will be a very interesting collaboration.
Okay, well, it's been a great pleasure. Thank you very much.
Thank you.